Okay, so now let's talk about and finish the arrhythmias. So now in the previous video, we talked about supraventricular arrhythmia. Now we're going to talk about ventricular tachyarrhythmias. Sorry, we're going to talk about ventricular tachyarrhythmias. Well, in the previous video, we were talking about supraventricular tachyarrhythmias. In other words, in previous video, we were talking about narrow QRS complex tachycardia. And now in today's video, we're going to be talking about wide QRS tachycardia, which is non-sinus arrhythmia, in which there's a disturbance in the rhythm of the sinus rhythm. Now, if you can recall the steps, if you remember the search pattern, step number 4, when we're assessing the sinus rhythm, we're asking ourselves 5 questions. The heart rate, the P wave, the QRS, the relationship between the two, and whether the rhythm is regular or irregular. Alright? And we were asking ourselves, okay, regarding the disturbance in rhythm, arrhythmia, it could be either issue of the speed in the sinus rhythm, tachycardia, or it could be a case of non-sinus arrhythmia from an ectopic source, like ectopic rhythm, re-entrant rhythm, which talked about in previous video, blocking conduction or accessory pathway. In today's video, we're going to be concerning ourselves with ectopic rhythm in the case of ventricular tachyarrhythmia. And in the next video, we'll talk about arrhythmia, in which we'll talk about arrhythmias due to non-sinus arrhythmia, due to blocking conduction, and due to accessory pathway. But in today's video, we're going to concern ourselves with ectopic rhythms and pertaining to ventricular tachyarrhythmia. Now let's revise one more time. Again, this is the heart. The vector is going inferiorlaterally towards the left. This is the SA node, the AV node, giving a shortcut pathway towards the left atrium, then towards the bundle of His, then towards the right and the left bundle branch, and eventually to the Purkinje fibers. Your normal sinus rhythm means your wave of depolarization should arise from the SA node. It generates between 60 to 100 action potentials. This one will outpace, it will overcome its competitors, its other pacemaker competitors, such as the pacemaker cells found in the atrium besides the SA node, or the AV node, or the pacemaker cells in the ventricles. The ones that are considered as atrial pacemaker cells, they generate between approximately 60 to 75 action potentials per minute. The AV node between 40 to 60. The ventricular pacemaker cells between 30 to 45. Mumtaz? So this is the normal scenario. And this will give us the normal sinus rhythm. Normal because the heart rate is within the normal range. The P wave is present. The QRS is narrow, so 0.08 seconds or less in duration. The relationship between the P wave and the QRS is present, and the rhythm should be regular. Alright? Now let's talk about ventricular tachyarrhythmias. Now, we have the first one, and the most infamous one, and by far the most dangerous one, which is ventricular tachycardia. Now, ventricular tachycardia has 2 forms. It could be monomorphic, or it could be polymorphic. What does these two mean? Monomorphic means that the arrhythmia can have one shape, one normal shape each time. Like in this one, and this one, and this one. They can have a normal exact shape each time. Or polymorphic means you have a ventricular tachycardia arrhythmia with more than one shape, different shapes. So one may become bigger, one may become taller, one may become even more taller. So in each QRS complex, they may have a different shape. So hence the term polymorphic. A mono, as in one, meaning you have one consistent shape. Now, let's talk about what does even ventricular tachycardia mean. From the name, you have tachycardia, but this tachycardia arises from the ventricles. What does that mean again? That means that this electrical potential that you see, a normal sinus beat, following this normal sinus beat, you see a couple of premature ventricular contractions, which if you recall in previous video, that means you have an ectopic source coming from the ventricular pacemaker cells, generating an action potential at 30 to 45 rate. where they are going in a bizarre direction. They're going towards the left, they're going towards the right, and they're very inefficient. They're very slow in depolarizing the entire ventricle. They're not coming from the normal pathway. They're going all over the place. This pacemaker going left, right, and it's very inefficient. Depolarizing the ventricles take time. So as a result of this ventricular pacemaker cell acting as an ectopic source, and if it occurs very early, this will give us the rise of a PVC, premature ventricular contraction, in which this occurs as soon as or even before the normal sinus beat finishes its repolarization, because you have a T wave and then you have literally as soon as possible the PVC immediately functioning. And what is the characteristic of a PVC or premature ventricular contraction? You'll have a wide QRS complex and you will not find any P wave, no P wave, because where is the source? From the ventricular pacemaker cell. So why would there be a P wave from above? It all comes from the ventricular pacemaker cell. So there's no P wave, no retrograde, no inverted, no P wave. Just a wide QRS complex. Mumtaz. And since it's occurring very early, this is known as premature. If it occurs late, such as in this one, where you can see a normal sinus beat, and let's say there's a sinus arrest or asystole, and then suddenly you'll see the presence of a wide bizarre QRS complex. This occurs following arrest. Then this is the same characteristic as this one. This is known as escape beat. Escape beat has the same characteristic in EKG as a PVC. The difference, this is premature. This occurs early, as soon as this one finishes its repolarization, or before it finishes its repolarization. But this one occurs late. This one occurs following sinus arrest. This one is life-saving, because this means the ventricular pacemaker cell, if the heart has stopped, or there's no action potential coming from the SA node, that means the ventricular pacemaker cell, they will generate their own action potential, and they will try their best to depolarize the ventricle so they can contract and pump blood. So this is life-saving. This is seen as like people with cardiac arrest, maybe, or people with complete heart block, third degree. But in a case of PVC, no, it's a nuisance. It is very dangerous. Mumtaz? Mumtaz. طيب. Now, one question. Why am I talking about PVC? Why am I talking PVC occurring here? What does this have to do with ventricular tachycardia? I'm glad you asked. They're the same thing. PVC and ventricular tachycardia characteristics, they're literally the same. The difference is progression. What does that mean? Well, in the world of EKG, there's something known as the rules of malignancy for a PVC. In most cases, a PVC might be harmless. It may be harmless, it might be benign. But there are certain scenarios, certain criteria, which can conclude that PVC can be malignant, it can be dangerous, it can convert itself into a ventricular tachycardia. So we can assume this as the benign form of ventricular tachycardia. And when it becomes malignant, it is truly ventricular tachycardia. So what is the criteria? What are the rules of malignancy that states, if you see this criteria, the PVC is dangerous. It can progress from a single PVC that can share its relationship with a normal sinus beat, 1-for-1, in the world of EKG bigeminy. They call this bigeminy as in 2. Instead of just being a normal benign phenomena, it can be very malignant. It can be very dangerous, because now it can convert itself to ventricular tachycardia based on specific criteria. What are those criteria? The following. If you see 1, 2, 3 PVCs consecutively, this is a confirmed case of ventricular tachycardia. If you see 3 PVC at a regular rate, no P wave, wide QRS, they occur at a regular rate, 3 PVCs consecutively, ventricular tachycardia, monomorphic. Mumtaz? Mumtaz. Now, another criteria. If you see a PVC, 1, 2, 3, and each of them have a different shape, each of them have a different morphology. This one is bigger, this one is smaller, this one is whatever. If each of them have a different morphology, this is another sign of malignancy. If you're seeing them frequently, throughout the EKG, this is a sign of malignancy. If you see a PVC in a person with a normal heart, it might be benign. But if you see this PVC in a person with a cardiac disease, in a person with acute STEMI, in a person with heart failure, in a person with any cardiac disease like MI, this is malignant. This is very, very bad. And one more criteria to write down, one more criteria to take note of. If you see a PVC and you see this P wave, they call it the R on T phenomenon. If you see the R wave of a PVC, if you see it falls on the T wave of a previous beat. You have a T wave of a previous beat in which this PVC jumped on top of it. It occurred on top of it. If you see the R on T phenomenon, where the PVC is literally within the T wave, it starts as soon as before this one finishes repolarization. If you see the R on T phenomenon, where the PVC is literally within the T wave of the normal beat from before, then this is another sign of malignancy. Mumtaz? So how many do we have? We have a total of 5. If you see 3 consecutive PVCs, if each of them have a different morphology, if each of them occur very frequently, if each of them occur in the setting of an acute cardiac disease like MI, and if you see the R on T phenomena, a PVC, it falls on the T wave of a previous beat. They can predispose to multiple PVCs, and eventually when you have 3 PVCs or more consecutively, this is confirmed case of ventricular tachycardia. When you have 3 of them consecutively or more. Mumtaz? Mumtaz. So, since we finished this talk, we finished ventricular tachycardia, monomorphic. But remind you, it can also be polymorphic in one scenario. We'll talk about that shortly. But for now, when we're assessing the sinus rhythm of ventricular tachycardia, and since we know the difference between PVC and escape beat, now let's talk about ventricular tachycardia, where the P wave here, non-existent. Mumtaz, it's non-existent. Now, what about the heart rate? The heart rate is obviously tachycardia. So let's say, for example, 150 plus, for example. What about the QRS? The QRS is wide, it's abnormal. Mumtaz? What about the rhythm? In monomorphic, it's regular. And polymorphic, it tends to be irregular. We'll see. So this one is normal, regular. What about the relationship? Non-existent. Because at the end of the day, ventricular tachycardia, where does it come from? Where does PVC come from? Where does this action potential, this depolarization, where does it come from? Why is it bizarre? Why is it wide? This is all because of the ventricular pacemaker cell, or any ectopic foci that's within the ventricles. Mumtaz? That's the reason why. So, this is a case of ventricular tachycardia. Any case of wide complex, anytime you see a wide QRS complex with tachycardia, always assume ventricular tachycardia until otherwise. Very dangerous. Now, let's talk about the next arrhythmia, which is practically the same as ventricular tachycardia, which is torsades de pointes, a French term. Torsades de pointes is a polymorphic ventricular tachycardia, a ventricular tachycardia that has more than one form, as we discussed earlier. Mumtaz? So how come we can have a ventricular tachycardia that's polymorphic and thus have an irregular rhythm? Not a regular and an irregular rhythm. How come we have torsades de pointes? Well, we have it in one scenario. If a person has a prolonged QT interval. Remember what we mentioned about QT interval in previous video? If we have the QT interval exceed 50% or more than 50% of the RR interval, basically the T wave is practically in the middle for this beat. This is a prolonged QT interval, and this is very dangerous. And unfortunately, it's very common. When is it common? Or why is it common? Because this prolonged QT interval occurs in people who use medications that prolong this QT interval. Like people that use fluoroquinolones and ACE inhibitors. Both of them together can prolong the QT interval, and they can increase potassium. Or people with tricyclic antidepressants, or people with haloperidol. Any medication you can think of, antibiotics, antiepileptics, antipsychotics, these can prolong the QT interval, especially when they're combined. And the problem with a prolonged QT interval, what do you think? What do you think is the problem when you have a prolonged QT interval? I'll tell you what's the problem. This allows for a PVC to fall on this T wave. Remember what we said about RMT phenomena? How one of the signs of malignancy is when a PVC falls on the T wave of the previous beat? Well, what if I told you that the PVC can easily fall on this T wave from a previous beat, and if we have a PVC, if we have a premature beat arising from the ventricle, or arising from anywhere else, but especially from the ventricles, if they fall in this T wave, this will give us multiple PVCs immediately. And thus, this can give us the rise of ventricular tachycardia. So that's the dangers of QT interval. When we have a prolonged QT interval, that makes it very easy for a premature beat from the ventricles, from the atrium, or whatever, to fall on this T wave. Since it's in the middle, it's not from before, from backwards. So if it falls on it, this can lead to the onset of a multiple PVCs and lead to the development of ventricular tachycardia. Or let's be more specific here, this can lead to the development of not just any ventricular tachycardia, this can lead to the development of polymorphic ventricular tachycardia, which is Torsades de Pointes. So Torsades de Pointes occurs in people in which you can see on an EKG prolonged QT interval. Mumtaz. And you can see the appearance of polymorphic ventricular tachycardia. Look at the difference of ventricular tachycardia monomorphic compared to Torsades de Pointes. Notice how the rhythm is irregular. Notice how you can see the bizarre white-shaped QRS, but they're disorganized. You know, they're going all over the place. They're undulating across the baseline. So across the baseline, they're undulating upwards, downwards, at a completely disorganized manner. So this is the key difference between this and this. It's an eye spot. It's a spot diagnosis where we see Torsades de Pointes. Mumtaz? So Torsades de Pointes, if someone asks you, which one is more severe? Do you think ventricular tachycardia or Torsades de Pointes? You'll say Torsades de Pointes. This is another form of ventricular tachycardia where it can become really, really bad. Now another one that can be very, very bad, we can think of it as the evolution. Another one that's very bad is now another arrhythmia, another white complex is ventricular fibrillation. This is seen in people with cardiac arrest. Now this one is better than in people with true cardiac arrest, people with asystole, people that have this, asystole, because there's electricity here, but it's still very bad. Yes, there's electricity compared to asystole, but it's very bad because this electricity actually is not causing depolarization for the ventricle. It's causing like fasciculation. It's causing like shivering for the ventricles. It's just touching it, but it's not pushing it. So this is seen in people with cardiac arrest, where you're basically causing shivering, or you're just touching the ventricle. You're depolarizing it, but there's not enough contraction. There's not enough contraction from this electricity. So this is still very, very bad. And you can think of ventricular fibrillation as like the final form of ventricular tachycardia. So ventricular tachycardia, in terms of severity, from top to bottom, or let's say from bottom to top, from this first stage, monomorphic. The second stage, polymorphic. You can think of it like this. So monomorphic stage 1, polymorphic stage 2, especially with people with prolonged QT interval. And then stage 3 is that eventually these ventricular tachycardias, they can eventually develop into ventricular fibrillation. And you can see basically the appearance of ventricular fibrillation. You can see you can have clearly a bizarre shaped and widened QRS complex. But the thing is, they're very disorganized. You don't even know where's the P wave, where's the R wave, where's the Q wave. You don't know what's going on. It's just a bunch of waves floating around. That's ventricular fibrillation. In fact, one of the key differences between ventricular fibrillation and Torsades de Pointes is that this one doesn't go undulate beyond the baseline. Yani this one, it doesn't undulate beyond the baseline. It doesn't go all the way towards up, all the way towards down. It stays within its realm. But you'll see that the QRS here, completely disorganized. You don't even know what's going on. At least with the Torsades de Pointes, you can see a resemblance of a QRS complex. It just has many different forms. and it's an irregular rhythm going up and down. But here in ventricular fibrillation, it stays within its range, now going up and down, and you don't even know if there's a rhythm, you don't even know if there's a QRS complex, it's just a bunch of disorganized wave. Because this is pretty much a bunch of electricity here in the ventricle going all over the place. And this is seen in people with cardiac arrest. Basically flickering of light, but it's not true light. Mumtaz, in ventricular fibrillation. So that's a case of ventricular fibrillation, how you can diagnose the case. Now, we finished with wide complex tachycardia. We finished them all. However, there is just one more wide complex tachycardia. Let me ask you a question. What if I told you you could have a wide complex tachycardia, but it arises from the ventricles from above? Huh? What is this? Nawaf, you told me that any supraventricular tachyarrhythmia will have a narrow QRS. Well, there is one exception. Not all of them. There's one exception. And that's in a case of AV-NRT or atrial fibrillation with aberrancy. With aberrancy. What does aberrancy mean? That means in a case of bundle branch block. What does that mean? What do you mean, Nawaf, there's one exception? What do you mean, Nawaf, when you tell me there's an exception where supraventricular tachyarrhythmia, there is a scenario where it can appear with a wide QRS complex? And if you're telling me this exception, how am I going to differentiate this Q wave? How am I going to differentiate this arrhythmia with aberrancy from ventricular tachycardia if both of them are wide complex? How will I differentiate? Well, let's start with a story. Let's talk about a story, all right? Let's talk about what does aberrancy mean. Aberrancy basically means the action potential, the wave of depolarization, instead of it going towards the normal conduction system, Mumtaz, and eventually depolarizing all the chambers, some of the wave of depolarization, they may be deviated. They may come to a chamber late. They may come to it very late, and they produce a wide and bizarre QRS complex without any P wave. Or if you do see a P wave, it's associated with AV-NRT, retrograde. Or you might see multiple P waves. You can distinguish it, associated with atrial fibrillation. So let's revise the story. What do we mean by that? By drawing on the heart. Now, remember what I said about previous video. Remember when I said about premature atrial contraction. Remember when we said about how when there's depolarization, Mumtaz, when there's depolarization and eventually repolarization, you know, a lot of the ventricles and a lot of the conduction system, especially the right and the left bundle branch, for example, they have a refractory period, you know? Just like when we talked about re-entrant rhythm, they have a refractory period, our conducting system, basically saying, when I am repolarized fully, give me the action potential. But if I am not repolarized completely, don't give me the action potential, go somewhere else. Here it is the same concept, where if we have a premature atrial contraction, we have a premature signal, a premature wave of depolarization coming from a pacemaker in the atrium or coming from a pacemaker of the ventricle, it can hit, for example, one of the bundle branches. And the bundle branches at this time are repolarized. You know, they're telling it we're in a refractory period. Go somewhere else, right? Well, here's the thing. Let's say in a case of AV-NRT. Remember AV-NRT, where we have a re-entering loop? Towards this re-entering loop within the AV node. Remember that in previous video? Well, let's say this AV-NRT, let's say it sends this wave of depolarization very early. Let's say we're in a system, let's say we're in a scenario of repolarization, all right? We're in a scenario of repolarization. And now the AV node, the re-entering loop, it sent another wave of depolarization, but way too early. It sent it before these are repolarized. Like let's say the left bundle branch or the right bundle branch. Mumtaz? Let's say the right bundle branch. So when this action potential that's very early, a premature beat, when it comes towards the right bundle branch, when it comes to it, the right bundle branch will tell it, no, I don't want this action potential. I'm in my refractory period. Go somewhere else. Mumtaz? So we'll tell it to, no, I don't want to come here. go somewhere else. So where will this electrical potential go? Is it going to stop? No. Now this wave of depolarization has come towards the left bundle branch instead of the right bundle branch. So if it comes to the left bundle branch, it will go ahead and depolarize the left ventricle as usually, right? Normally. However, here's the thing. Let's say by that point, the right bundle branch, it's happy. Now I'm not in my refractory period. Send me the action potential. But guess what? AV node is going to tell it, bro, I did send you this action potential. I did send it to you. You didn't want it. So I gave it to someone else. I gave it to the left bundle branch. And the left bundle branch now depolarized the left ventricle. And now guess what? Now this wave of depolarization, since I didn't depolarize the right ventricle, this wave of depolarization that went to the left ventricle, it will now come to the right ventricle. It will now transfer itself towards the right ventricle, towards this side. Mumtaz? This wave of depolarization from the left ventricle, now it starts to come to depolarize the right ventricle, which was not depolarized. And when that happens, if you notice, when that happens, when the wave of depolarization is no longer going the normal pathway, it's not depolarizing the right ventricle towards the right bundle branch, instead it's coming from the left ventricle towards the right ventricle, this will produce for us, from the perspective of lead-2, this will produce for us a bizarre and wide-shaped QRS complex with AV NRT. So, in the context of AV NRT, when you have a premature beat, and especially with someone who has a bundle branch block, whether it's an actual block here or due to a premature beat from the AV node, this will give us AV NRT with aberrancy. The transfer of a wave of depolarization from the left ventricle towards the right ventricle or vice versa, abnormally, not from the normal pathway, from another site. So this will produce for us an AV NRT, in which you might see no P wave. You might see a retrograde P wave. But regardless, you will see accompanying it a wide and bizarre shaped QRS complex, because the wave of depolarization is going towards the right ventricle, away from the lead-2, away from it. So this is AV NRT with aberrancy. And the same concept with atrial fibrillation, the same concept. You have an multiple ectopic foci in the atrium, sending too many early beats, and the right bundle branch told it no, went the other way, and now it comes towards the right ventricle that was not depolarized. The same concept, Mumtaz, where you have multiple P waves. For example, you'll see in lasers multiple indistinguishable P waves, but a bizarre wide-shaped QRS complex. So that is the meaning of aberrancy. When there's a block in the bundle branch and telling it, no, I don't want it. I don't want it. Mumtaz? So, now that we explained this, AVNRT or A fibrillation with aberrancy, now that we've explained this, now the question is, how can I differentiate this from ventricular tachycardia? I'm glad you asked. Yeah, there's a couple of differences. From a clinical view and from an EKG view. From a clinical perspective, it's easy. AVNRT, for example, Jama'ah, or any supraventricular tachyarrhythmia, any supraventricular tachycardia with aberrancy, you can differentiate, especially AVNRT, because in clinically wise, it occurs in people with a healthy heart. Remember? People with a healthy heart. They just take drugs, alcohol, or whatever. But in ventricular tachycardia, in such a serious arrhythmia, this occurs in people with a diseased heart. People with heart disease. Mumtaz? Also, AVNRT, remember the treatment? You can do a carotid massage. You can massage the carotid and manipulate the parasympathetic input on the SA node and the AV node. And this can terminate the AVNRT. But if you do the carotid massage on ventricular tachycardia, no effect. So that's two ways of differentiating this from this clinically. Now what about EKG? You can also differentiate between this and this in terms of EKG finding. For example, if you find the QRS complex, if you find it, for example, positively deflected, the first one, the first bizarre white-shaped QRS complex, if you find it's positively deflected, then this can reflect AV and RT. ممتاز. But in ventricular tachycardia, this can be negatively deflected. So the deflection in the first QRS complex, not all of them, just the initial one, the first one. If you see the deflection positive, AV and RT. But if you see the initial white-shaped QRS complex is negatively deflected, it's ventricular tachycardia. You want to differentiate between the two further, you'll find the difference between the two, which is something known as AV node dissociation. AV node dissociation, you'll find this in ventricular tachycardia, but you will not find this in AV and RT. And what does AV node dissociation mean? We'll know in the upcoming video. It means the atrium, they depolarize لحالهم, and the ventricle, they depolarize لحالهم. They both work independently. That's the meaning of AV node dissociation. And you can see this condition, it is associated with ventricular tachycardia, but it will never be seen in AV and RT. ممتاز? ممتاز. There's also a couple of differences, but so far that's as much as we can mention. So there's two ways of differentiating it clinically, with the one is in a normal heart, one is in a diseased heart. Carotid massage works here, carotid massage doesn't work here. On EKG, you might see the initial QRS, the first one, positively deflected, this one could be negatively deflected. This one may show no AV dissociation, but in the majority of ventricular tachycardia, they are associated with AV nodal dissociation. So I just want to let you to keep in mind, be aware of this condition. This should be part of your differential diagnosis. But obviously, the first one you should think of when you see a wide complex tachycardia is ventricular tachycardia. But you should always be aware, in EKG, there's always exceptions. There's always exceptions, such as a supraventricular tachyarrhythmia with wide complex in the context of aberrancy. Aberrancy meaning the transfer of an abnormal action potential from an abnormal site to another. ممتاز? ممتاز. Now we have finished, practically we finished 90% of the arrhythmias. What remains is the remaining 10%. Now we want to talk about in the next video, non-sinus arrhythmia due to conduction block and due to accessory pathway, Wolff-Parkinson-White syndrome. ممتاز? So before we end the video, now that we talked about ventricular tachycardia, and to say this, the point is, and AV and RT with aberrancy and ventricular fibrillation, and we talked about PVC, and we talked about escape beat. Now to end this video, we'll talk about the treatment of the arrhythmias. Let's summarize quickly the treatment or the treatment approach through the arrhythmias, supraventricular and ventricular tachyarrhythmia. ممتاز? ممتاز. So, the treatment in the context of cardiac arrest. ممتاز? If there's a patient who's unconscious, no pulse, no breathing, ممتاز? At this point, you're contemplating, do I continue with CPR or do I give him a defibrillation? Do I give him a shock wave from a defibrillator machine? Or do I give him a cardioversion? So, when I attach the patient who's in a case of cardiac arrest, he's unconscious, I'm following BLS algorithm, I'm following advanced cardiac life support, I'm following tachycardia algorithm. So when I'm attaching this patient who's unconscious with no pulse, or let's say he has a pulse or whatever, let's say this patient is unconscious and I attach this patient to a defibrillator machine, AED, a defibrillator. The defibrillator machine will show me the rhythm. It will show me the rhythm. ممتاز? Is it shockable or non-shockable? Do I give him the shock or do I not give him the shock? What does that mean? Well, let's summarize the management. So, to summarize, first thing first, when you see in a defibrillator machine, the machine will show you on its monitor similar to an EKG. It will show you the rhythm tracing, ممتاز? It will show you the rhythm tracing and it will tell you, could this be ventricular tachycardia? Could this be Torsades de Pointes? Could this be ventricular fibrillation? Whatever, right? Whatever. So it will show me the EKG tracing on the defibrillator machine. And if I see it, now I can decide. For example, in the case of wide complex tachycardia, if I see ventricular tachycardia, if I see it, wide complex tachycardia, ventricular tachycardia, if I see it, now I need to decide. Is this patient, does he have a pulse or does he not have a pulse? if the patient doesn't have a pulse, meaning when he assesses carotid, he has no pulse, but there is ventricular tachycardia, well, I will immediately, my management, shock the patient. Give him a shock, then continue CPR for around every 2 minutes. Continue CPR, you might give this patient epinephrine along with it. So, when you have a patient who has ventricular tachycardia but no pulse, you give this patient a shock from the defibrillator machine. The same machine that was showing you the rhythms tracing. You give him a shock from the machine, then continue with CPR, ممتاز, until this patient regains consciousness. However, if you have a patient with ventricular tachycardia and he has a pulse, now you need to decide, is this patient stable or unstable? What does stable, unstable mean? Stable means this patient, he has ventricular tachycardia with stable vital signs. He is not hypotensive. He is not hyperthermic. He doesn't have a low blood pressure. He's not tachypnic. He doesn't have signs of heart failure. So he's relatively stable according to his vital signs. Oxygen saturation, normal. So if I have a patient with a stable ventricular tachycardia, I'll give this patient medication. Arrhythmogenic medication, prokinamide, lidocaine, whatever. I'll give him medication. However, if I find that this patient is unstable, he has ventricular tachycardia with a pulse, and he's unstable, heart failure, hypotensive, decreased oxygen saturation, whatever, if he's unstable, I will give him a shock. But this shock will not come from the defibrillator. It will come from his brother, the little brother, cardioversion. The cardioversion will give a shock in synchronization with the QRS complex. So, in the case of unstable ventricular tachycardia with a pulse, cardioversion. But he has a pulse and the person is stable, I'll give him medication. If he has ventricular tachycardia without any pulse, no pulse, I'll give him a shock wave from the defibrillator, followed by CPR. ممتاز? Now, good news. The treatment that I mentioned now for ventricular tachycardia, it is the same treatment for all of this. For all of this. If you approach a wide complex tachycardia in the context of cardiac arrest, or in the context of person approaching you with tachycardia, any case of wide complex tachycardia, you must treat it as if it's ventricular tachycardia. It's ventricular tachycardia until otherwise. The treatment is the same that I just mentioned. ممتاز? For all wide complex tachycardia. ممتاز. Now, what about the treatment for supraventricular tachyarrhythmia? With the exception of this one, you can ignore this. What about atrial fibrillation? What about atrial flutter? What about AV NRT لحالها? What about the treatment for this one? Well, it is the same concept. The same concept. Meaning, what I mean by same concept, I mean, you decide, is this patient, does he have a pulse? Or does he not have a pulse? And if he does have a pulse, is he stable? Or is he unstable? The concept is almost the same, but there is just a key difference. ممتاز? Just one simple difference. You see, if you have any supraventricular tachycardia, and he has a pulse, and he's stable, give him medication. But if he's unstable, put him in cardioversion. Easy? Easy. But what if we have a supraventricular tachycardia that has no pulse? They give it a term in general. They give this a term. They call this PEA. PEA, pulseless electrical activity. From the name, PEA. So if you have a case of a PEA, any supraventricular tachyarrhythmia without any pulse, what do? Do I give him a defibrillation? No. I will not give him the defibrillator. I will not give him a shock. Instead, I will continue with CPR. I will give him CPR every 2 minutes until I have a shockable rhythm. If I have a shockable rhythm, go ahead. If you don't have one, continue CPR until the patient regains consciousness. ممتاز? Then we go with a different care once he regains consciousness. ممتاز? But regardless, in summary, in supraventricular tachyarrhythmia, the treatment is the same as ventricular tachyarrhythmia. Almost the same. But when you have a case of supraventricular tachyarrhythmia without any pulse, give him CPR. No defibrillator, none. So if you think about it, we give defibrillation, we give the shock wave from the defibrillation when we have ventricular fibrillation and when we have ventricular tachycardia pulseless. ممتاز? Otherwise, it's CPR. If he is pulseless, and if he does have a pulse, it's unstable, cardioversion. ممتاز? ممتاز. So now that we finished that, of course there's also a bit more details about the management. Like for example, in sinus tachycardia, generally you don't even do any of this. You just treat the cause. So in some arrhythmias, you just treat the cause, like sinus tachycardia. Or people with multifocal atrial tachycardia. You remember Matt from previous video? That was due to hypoxia, chronic lung disease. So if you treat the chronic lung disease, hypoxia, you treat the cause, you treat the arrhythmia. So there's also a couple of exceptions. But in general, this is the main management approach to the arrhythmias in the context of cardiac arrest. ممتاز? ممتاز. Following BLS. ممتاز? ممتاز. خلاص. We now finished the arrhythmias. We now finished it. And now in the next video, we will finally finish the remaining 10% of arrhythmias, which we will talk about conduction blocks and Wolff-Parkinson-White syndrome, which is accessory pathway. See you in the next one.